I'm Dr. Richard Finn from the Geffen School of Medicine at UCLA. I'm an associate professor of medicine in the Division of Hematology Oncology at the Johnson Comprehensive Cancer Center at UCLA. So we recently had a study published in the New England Journal of Medicine, the November 17th, 2016 edition, and this were the results of a large randomized phase 3 study evaluating the combination of palbociclib and letrozole versus letrozole and a placebo in women with advanced breast cancer. Palbociclib is a novel agent. It's the first of its class to be approved by the FDA and other regulatory agencies. And palbociclib has a unique mechanism of action in that it blocks specific proteins that are key in regulating the cell cycle. The proteins it blocks are called cyclin-dependent kinases, specifically cyclin-dependent kinases 4 and 6. And by doing so, the goal is to block cell division and progression and growth of cancer. So the development of palbociclib and other drugs in its class really followed a rational clinical development program. The idea of using this drug in a specific type of breast cancer came out of laboratory work done here at UCLA by myself, my colleague Dennis Slayman, in collaboration with Pfizer. Key to the development of these type of novel drugs in cancer medicine is to identify the right population that will respond. A group of breast cancers we know are not all the same, and that using laboratory models we identified that ER-positive and HER2-negative breast cancer, that this group of breast cancers seemed to be very sensitive to the growth inhibitory effects of a drug like palbociclib. And with this, we developed initially a phase 2 study looking at palbociclib in combination with a very standard endocrine treatment for breast cancer, letrozole. And that study, the Paloma-1 study, which was published in Lancet Oncology in 2015, was a smaller study, about 165 patients that were randomized 1-to-1, or half the patients got palbociclib and letrozole, the other half got letrozole alone. And that study showed a really significant improvement in progression-free survival, or the time it took for a patient's breast cancer to grow while being on the study. And specifically, it showed that we increased progression-free survival by over 10 months. So with that in mind, the FDA did give palbociclib an accelerated approval, but there was always a commitment to do what we consider a definitive study in clinical medicine, which is a randomized placebo-controlled study. So the study in the New England Journal of Medicine recently was called the Paloma-2 study, or Trio 22. And this study enrolled 666 women and randomized them in a double-blind fashion to getting letrozole and a placebo, which is standard treatment, letrozole, or letrozole and palbociclib. And a study of 666 patients gives us a lot more confidence in the result, that it might not just happen by chance. And again, remarkably, really recapitulated the result that we saw in the phase 2 study, and that is a more than a 10-month improvement in progression-free survival. Really, that's decreasing the risk of progression by over 40%. And this isn't a small population of patients we're talking about. Breast cancer is really made up of several molecular subtypes of the disease, and the ER-positive, HER2-negative group is really the largest group of patients, representing over 60% of patients we see with breast cancer. So when we think about advanced or metastatic estrogen receptor positive breast cancer, this is breast cancer that has spread beyond the breast. For many patients, they had breast cancer sometime in the past. It was localized to the breast and it was treated, and we thought these women might be cured, but then the breast cancer came back in another location, such as the bone or the lung or the liver or another site. Or there was a subset of women who just presented with advanced breast cancer as their initial presentation, meaning by the time they found a mass in their breast, there was already disease that had spread. And estrogen receptor breast cancer, estrogen receptor positive breast cancer, has several standard treatments available to them. These patients have available drugs that are actually very effective. These include drugs that alter the response to estrogen, one of the key drivers, or that decrease the amount of estrogen in the circulation, and then also standard chemotherapy drugs. So the overall survival, the time a woman can live with this subtype of breast cancer, is actually measured in years, somewhere in the 3 to 4 year range. It's not curable, but patients can live a fair period of time. So if we have patients who are newly diagnosed with metastatic disease and are evaluating a new therapy, to get an overall survival result will take several years just because of the natural history. So what we often use as a surrogate for overall survival is this endpoint called progression-free survival. And progression-free survival is measured typically using CT scans or also sometimes just with a clinical assessment, but typically with CT scans measuring the amount of growth in a tumor once a patient starts on study. And when we say progression-free survival, that's the time period between a patient starting on drug until they progress either clinically or radiographically by a certain amount. And typically on a scan, that means their total tumor burden has increased by about 20%. At that point, we call that progression. So the time from starting drug until we call progression is what we call progression-free survival. And the thought is that it's a very meaningful endpoint. For one, because in some cases it does correlate with overall survival, but specifically in estrogen receptor positive breast cancer, it's felt that if we can increase progression-free survival without compromising a patient's quality of life or inducing too much toxicity and delay the time that it takes for them to start chemotherapy, that is also a very meaningful endpoint. Ultimately, that's our goal, I think, in cancer medicine, is to introduce drugs that not only shrink tumors or delay their progression, but actually help people live longer. We know from studies with older drugs that just causing tumors to shrink don't necessarily help people live longer. We have a little more confidence that maybe progression-free survival correlates better with overall survival. In the phase 3 study, it will take time to see that survival data, specifically because the natural history is several years. And if progression-free survival is increased by 10 months, then hopefully overall survival is increased somewhere in that range, or more realistically, a little less than that, just because as patients go on to other therapies over the course of several months to years, some of that progression-free survival benefit may be whittled away, especially in the frontline setting. But hopefully we will have a glimpse at overall survival from the smaller phase 2 study, the Paloma-1 study or the Trio 18 study that finished a little while ago, actually well over a year ago, and we'll have a glimpse hopefully of overall survival from that study in the near future.